Okay, team, as we're promised today in class, I'm going to go through some of these cases, talk through how I kind of approach them, and maybe kind of clarify some things from class today. So let's start out with case 1. The patient's chief complaint is I feel very confused and I cannot think. I would highly suggest going ahead and trying to do the cases first by yourself and then coming back and looking at how I did it, as opposed to just like watching me do it. So if you haven't yet, stop, pause, look through the first case, try to figure out the answers yourself, and then we'll come back and discuss it. But I'm going to keep going. CJ is a 37-year-old Korean female who reported in the ED after altered mental status, reporting altered mental status, dizziness, increased urination that's progressively worsened over the preceding 4 days. They have a diagnosis of hypertension, osteopenia, and vitamin D deficiency. Drinks 1 to 2 alcohol drinks weekly, no illicit drug, vegan diet. On hydrochlorothiazide, cholecalciferol, and calcium carbonate. We can look here at their physical exam. They're confused. They have vital signs listed here. Poor skin turgor, prolonged capillary refill times, mucous membranes are dry. You can see a lot of different things in this physical exam that we'll kind of talk through. And then I have their labs listed here. So, the first question is this patient hyper or hypovolemic? Justify your answer with the patient's presentation. So let's kind of start looking through this presentation here. So they mentioned altered mental status, dizziness. Okay. They have increased urination, which may make us think excessive losses. They're very confused. They're tachycardic. Their blood pressure is low, like less than 100. Poor skin turgor. Prolonged capillary refill time. Mucous membranes are dry. Let's see if there was anything else that we should point out here. Let's look at their labs. So that's like in their physical exam. Thinking about their labs here, we can see that they have no BNP reported, but they do have a BUN and a serum creatinine that's greater than 20.21. So, do you think this patient is hyper or hypovolemic? Hopefully everybody's yelling like it's Dora the Explorer that it's hypovolemic. If we were going to justify our answer with the patient presentation, we already kind of did this. So we talked about the altered mental status and dizziness, that they had poor skin turgor, poor capillary refill time, dry oral mucosas, hypotension, resting tachycardia, and that elevated BUN to serum creatinine ratio. Some of the less specific signs could be that altered mental status and the fatigue and very confused, all making us lead to thinking that this patient is hypovolemic. Capillary refill time, dry oral mucosa, hypotension, tachycardia, and then high BUN to serum creatinine, aka greater than 20 to 1. Okay, for the exam, make sure that you can figure out whether the patient is hyper or hypovolemic. We'll have some examples of hypervolemia in a moment. Okay, our next question. Which fluid would be the most appropriate for the patient considering the information presented? So let's look at some of the information presented and some big things that we would look at. Number 1, we know our fluids can either be crystalloids or colloids, right? Now, I want everybody to remind me, which one are we going to use for fluid management primarily? Based on the lectures. Again, like Dora the Explorer, you guys are hopefully all yelling crystalloids back at me. Because crystalloids are less expensive, have less side effects compared to colloids, and have not been shown to have any difference in clinical outcomes. So we're going to look at crystalloids. Now, when we think about crystalloids, we have normal saline, LR, and D5. So normal saline and LR are primarily used for fluid resuscitation. D5 water is not going to be used for fluid resuscitation because it's just free water, and it doesn't really help with intervascular spaces filling up. So that makes us think that D5 is not for resuscitation. You may use it in maintenance sometimes. Okay, so normal saline versus LR. What are some differences between these two? So let's start out with going down our lab values here. Sodium. Normal saline has high sodium, so we typically will reserve it for people who are hyponatremic. Versus LR can cause hyponatremia. If we think about potassium, if somebody is hyperkalemic, we avoid LR. Other things to keep in mind, if somebody has a metabolic acidosis, we might avoid normal saline. If somebody has a metabolic alkalosis, we may pick normal saline, things like that. So let's look at our patient here. Their sodium is low, their potassium is normal, and their chloride is normal. Bicarb is slightly high. So they're slightly basic, and they have hyponatremia. This makes me think that this patient actually would be the best candidate for, everybody say it with me, normal saline, because they have low sodium, they have high bicarb. LR is not a good choice because it can make the hyponatremia worse. D5 is not a good choice because we don't really use it for resuscitation. The patient is underloaded. And then colloids are really used second line, or those for those who are resistant. Okay. Calculate the patient's maintenance fluid requirements using the Holiday-Seeger. What's her 24-hour requirements and what's her hourly requirements? So let's remind ourselves what the Holiday-Seeger equation is. Okay, so this patient is less than 50 years old. She's 37. So her being 37, the equation would be 1,500 plus 20 times kilograms minus, 20. Took me a minute there. So the patient weighs 68 kilos. So that should give me about 2,460 mils per day. Now, I did ask what her 24-hour requirements are, but then also what is her hourly requirement. So if we want to know what so this is her daily requirement. So what's her hourly requirement? Well, we would just divide this by 24. So 2,460 divided by 24. That should give me 102.5, which is approximately 100 if I asked you guys to round to the nearest 25. And that's in mils per hour. I am sorry that my handwriting is horrendous at times. Okay. Our next part here is the patient is hospitalized and the patient's ABG is as follows. We have 7.56, 45, 98, 30. Their urinary chloride is 7. So, classify the patient's current Aspie's disorder is our first question. So, let's go ahead and think here. Is the pH high or low? Hopefully you're all yelling at me high, or said it very loudly in your head. PaCO2, high or low? once again, high on the borderline, but we'll say high for today. And then the oxygen we don't really care about. Bicarb, high or low? High. We're all going the same way, so that makes us think. Number one, we know that it's an alkalosis because your pH is greater than 7.45, so we know this is an alkalosis. And since they're all going the same way, that's a metabolic. Going back and looking through, we can kind of see that because their bicarb is high. They are trying to overcome it with the PaCO2, but it's not working, and that's why their pH is high. Their urinary chloride is 7. So, is that chloride responsive or chloride resistant? That's responsive because that urine chloride is less than 10. What is the most likely cause of this patient's acid-base disorder? So let's think about some of the causes for metabolic alkaloses that are chloride resistant. If you remember those top 3 that we talked about, were diarrhea, diuresis, and NG tube suctioning. Looking at this patient, do you see any of those things going on? So they've reported increased urination. They're on hydrochlorothiazide. That really makes me think that the problem is probably excessive diuresis / increased urination. Okay. Hopefully that all made sense to you. If you have any questions, please contact me. So let's go ahead and go to case 2. If you guys haven't noticed, my iPad is yelling at me that it's almost out of power, and it's also almost out of battery in my pen. So let me actually let that dock for a moment. MS is a 78-year-old Hispanic female with a past medical history significant for heart failure with reduced ejection fraction. She presents with complaints of shortness of breath with +4 edema. What is this patient's most likely fluid volume status? So they're complaining of shortness of breath and edema. She has a history of heart failure. This all makes me think that this patient is hypervolemic. When we talk about what other physical exam abnormalities, vital signs, and general complaints and laboratory values would you find? General complaints, they're already complaining of shortness of breath. We don't say SOB, we say SOA for shortness of air. We would probably expect that this patient has dyspnea on exertion. You'll see that this is actually abbreviated as DOE, and then leb swelling. For physical exam, we have that peripheral edema. Anasarca would be something that we would see, pulmonary edema, and ascites. Vital signs, rapid weight gain. Labs, elevated BNP. So hopefully these are some examples of some things that we would expect for this patient. Don't forget to be able to identify if the patient has hypovolemia or hypervolemia. Okay, we're on to 3. This patient's chief complaint is very specific. And again, pause, do it yourself, and then come back and we'll chat through it. But this patient's complaint is, I feel awful. JP is a 56-year-old African-American transgender man with complaints of feeling off for the last few days. He states that he's noticed that his urine looks funny and his back hurts really bad. He has some complaints of fevers and chills. Past medical history includes diabetes, hypertension, alcohol use disorder, hyperlipidemia, and chronic pain. Aspirin, metformin, atorvastatin, lisinopril, empagliflozin Oxycodone and hydrochlorothiazide are their medications. He has his physical exam listed here, along with his ABG. So, our first question here is to calculate the patient's acid-base disorder. So, let's start out with this acid-base disorder. So, we have our ABG listed here. Is his pH high or low? Low. So, we know that it's an acidosis. Is his PaCO2 high or low? Low. We don't really care about his oxygen today. And then is his bicarb high or low? It's low, Dr. Joyner. So we have somebody with a metabolic acidosis. Because you can see here that the patient has has a pH that is low and a bicarb that is low. And as a compromising or a compensating mechanism, we're trying to blow off that extra acid through the CO2, and that's why that is low. So we would put here metabolic acidosis. Calculate the patient's anion gap and osmol gap, and then calculate the patient's acid-base disorder. So let's start out with anion gap. So if we remember, anion gap is pluses minus minuses. So we do sodium minus chloride minus bicarb. So the patient's sodium is 138. Patient's chloride is 97. And then while I'm here, bicarb is 13. So what do we get? Is that an anion gap? So we get 28. Is that an anion gap metabolic acidosis? Yes. How do we know? Because this anion gap is greater than 12. Remember, 12 is our magic number there. So now let's try to calculate his osmolality. And luckily we have a lot of the data already here. So his osmolality equals 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. So let's plug and chug that. So it's 2 times 138 plus your glucose is 200. And while I'm here, BUN is 25. So 200 divided by 18 plus 25 divided by 2.8. Okay, let's plug and chug that into your calculators. You should have got about 296. Now, we're not done yet because we want to make sure that we look at their osmol gap. So remember, osmol gap equals the measured osmolality minus the calculated. So 300 is the measured. We saw that here in this table. Minus the calculator, which is 296. That gives me 4. So, calculating this, we know that it is an anion gap metabolic acidosis. Our osmol gap is not significant, so we know that it's not because of alcohol. So, using the lab values, what is/are likely cause of the patient's acid-base disorder? Well, let's go look at the lab values. Okay, so if we remember correctly, some of the big things that we're going to look at in order to determine a metabolic acidosis cause is the osmol gap. That would tell us that it's alcohols, right? We have Beta hydroxybutyrate, that will tell us if it's ketoacidosis. We have salicylate levels, that would tell us if it's aspirin toxicity. We have lactic acidosis, that would tell us if it's a lactic acidosis. So lactate will tell us if it's a lactic acidosis. So, looking at and then we would also look at their EGFR. If that's less than 30, that would tell us that it is maybe due to renal function. So, looking at this patient, osmolality we've already ruled out. We knew that that was 4, so the osmolar gap was normal, so it's not because of alcohols. Beta hydroxybutyrate is less than 1, so it's not that. We didn't check a salicylate. I don't see any salicylates in here. So that's kind of ruined, or there's nothing in their history that would make you think that it's a salicylate. If I were, I could probably check. Let's look here. Their EGFR is not listed, but their creatinine clearance is normal. So that makes me think that they're probably okay. They don't have a history of CKD. So let's mark that one out. Lactate. So their lactate is 5. Normal is between 0.5 and 2. It seems like they have a lactic acidosis. We know this because it's an anion gap, metabolic acidosis, so we think mud piles or gold marks. One of those is lactate. We know that this is likely caused by L-lactate because that's the more common. He doesn't have short gut syndrome. He doesn't have any other things that would make me think that it would be a D-lactate problem. Now, if we think type A versus type B, it does look like he has some things that would make you think that it's possibly a lactic acidosis due to sepsis. They have a fever, and like tissue hypoxia. They're not really perfusing very well, and then they're also on metformin. So it's hard to tell if it's a type A or a type B. So it could be type A due to sepsis or a fluid under resuscitation, or it could be type B and do the metformin. One or the other. You don't have to be specific. So if I were going to try to design a treatment plan, I would probably DC the metformin because that might be a causative agent. And honestly, if somebody has lactic acidosis, that's what you're supposed to do. Provide fluids such as LR or NS. Since the patient's sodium is normal and they're not hyperkalemic, I would probably pick LR. Vasopressors if needed. Oxygen supplementation, especially if they are hypoxic. It doesn't seem like they are. I don't remember what, I think they were setting at 90. But that could be a possibility. And then also treating the underlying cause, things like antibiotics. Big things I want you to be able to do here is identify that's a lactic acidosis, know the difference between an L type and a D type, and know the difference between A and B. You won't have to be able to actually tell me which one it is. Just know, like, based on the information I gave you in this case, I wouldn't have expected you guys to know that. And then just kind of know this fluids, vasopressors, and oxygen as being big parts. Okay. Case 4. If you feel like it, you can pause. If not, we can keep going. BW is an 88-year-old white female who presents with fluctuating confusion and slurred speech. Their medical history is listed here. They have diabetes, hypertension, heart failure, CAD, and atrial fibrillation. Isn't it so fun to just, like, know these words-ish? You guys are actually getting to, like, work through real cases here. Their medications are listed here, along with their physical exam. We do note a few medications in here that might be interesting. Their labs are listed here. So I have their ABG, their urine electrolytes, and then their labs. So let's start out with classifying the patient's acid-base disorder. So let's look here at this ABG. So it was 7.22, 30, 88, 15. We don't really care about O2. So 7.22, high or low? Low. 30 for the PaCO2, high or low? Also low. For the bicarb, high or low? Also low. All going the same way. Easy way to remember that it's a metabolic problem. Also, you can kind of think through it as far as the primary problem is that there is a low bicarb. Having a low PaCO2 does not make sense in this acidosis, right? But the driving thing can be this low bicarb, and then what we're doing to compensate is having the low PaCO2. So it's a metabolic acidosis. I'm really living on a prayer with this pen. Okay, next thing was calculate this patient's anion gap and interpret its finding. So let's calculate its anion gap. So chloride, sodium is 35, chloride is 112, bicarb is 15. So let's go ahead and say, oh, I lost my work. Here we go. So remember, it's sodium minus chloride minus bicarb, pluses minus minuses. So our sodium was 135. Our chloride was 112. And our bicarb is 15. 135 minus 112 is 23 minus 15 would give me 8. So, is that a significantly elevated anion gap? No. So we're going to think non-anion gap. Metabolic acidosis. So let's think about what is the likely cause of this patient's acid-base disorder. Slurred speech and confusion. I'm not really seeing that the patient's receiving any fluids. Oh, sorry. Right? No noted fluids. I'm not seeing a lot of excessive losses. Their potassium is high. And we do know it's a metabolic acidosis that's non-anion gap. So we always think accrued as our non-anion gap, with our big ones being that we're looking for acid infusions, we're looking for diarrhea, and we're looking for RTAs. So knowing that this patient has hyperkalemia, we couldn't find any diarrhea, we couldn't find any fluids, extra fluids, and that they're on spironolactone and lisinopril, this really makes me think that this is a type 4, because hyperkalemia. RTA, design a treatment plan, stop spironolactone / lisinopril ifable. Give the patient, or correct, hyperkalemia. Any questions here? Okay. Again, take a moment. I will tell you guys that this case has a little bit of a trigger warning. It does deal with ED and ED complications, so like eating disorders. So just let you know. But let's keep looking at this. So JL is a 29-year-old Ethiopian female who presents to the ED with complaints of generalized weakness, fatigue, myalgias, and throat pain. She's lost 30 pounds since her last office visit 1 year ago. On examination, her throat has an erythematous pharynx and scattered exudations consistent with bulimia. The patient has no reported medical history. She reports smoking 1 pack per day, drinks socially, but has 4 to 5 binge drinking episodes. You can see here some of the patient's medical history, physical exam, and then their labs are listed here. So our first question is, classify the patient's acid-base disorder. Wow, what a question. Haven't seen that one before. So acid-base disorder for this patient. So let's look at this ABG. Is their pH high or low? High, because it's greater than 7.45. PaCO2? Right on the border, but high. Their bicarb? High. So they're all going the same way. It's primarily focused on the fact that this patient has high bicarb causing this metabolic alkalosis. So this is a metabolic alkalosis. And let's just take it one step further. Chloride responsive or chloride resistant? Urine chloride's less than 8, so this is chloride responsive. What's the likely cause? I would say that if we think about our chloride responsive patients, we really think about excessive GI losses, NG tube suctioning, and diuretics or excessive urination. This patient did have excessive GI losses through bulimia, so I would say excessive GI losses. Design a treatment plan for this patient. So this patient has a metabolic alkalosis. We know it's chloride responsive. So if you look at our little diagram here, the first thing we would look at is whether or not it's chloride. Once we know that it's a metabolic alkalosis, we look and see if it's chloride responsive or chloride resistant. It's responsive. Then we see if the patient has an initial pH of greater than 7.6. Do they? No. So that brings us down to, so we're not going to give acids. What we are going to do is check their volume status. So are they hypovolemic or hypervolemic? So let's look here. They have prolonged capillary refill time, skin turgor, mucous membranes are dry, they are tachycardic, hypotensive. Let me see if there was anything else. Generalized weakness, fatigue, and myalgias. These are all leaning towards hypovolemic. So what do we do to treat hypovolemic patients? Normal saline. So if the patient does not respond well, what would be a second-line therapy? We would consider things like acid infusions like HCl, ammonium chloride, argonautic chloride, things like that. Okay, that's my last one. If you guys have any questions, please feel free to contact me. Hopefully this was helpful to watch me kind of walk through the cases. Happy to do anything like this again. Yeah, just let me know.